That sounds great. Thank you so much. And a warm thank you for having me this morning. I'm excited to spend this time in this webinar together. My name is John Horton. Um, I am a psychiatrist and palliative care doctor at UCLA in Los Angeles, and a staff psychiatrist at the UCLA Sims Mann Center for Integrative Oncology, as well as working in the hospital at UCLA as a palliative care attending physician. Um, I moved through my psychiatry training and found myself compelled by and interested in learning more about how patients and families are learning about and coping with serious illnesses, and pursued extra training in hospice and palliative care after my psychiatry training, and find myself working at that intersection, working with medical students and residents and fellow physicians, folks that are interested in allied health in general, um, and really looking to learn more and work at an intersection where we can bring better tools really to patients and families and even clinicians working to care for folks living with serious illness. So really excited to talk about this intersection with psychedelics and palliative care, and we'll maybe pause there and pitch it over to you.
Thank you so much, John. It's really nice having you. I think it's worth going back to how we met, and that was a few years back at a conference called Manifest Mind in Los Angeles, hosted by Tom Broad, who's I think one of your mentors and someone that I've been learning a lot from as well over the years. And that was an interesting time. It was basically early on where in Canada we got access to psilocybin therapy for palliative patients. And
Mm,
so, yeah, I think I had just treated my first patient then, and you were a fellow in palliative care at UCLA. And we had a brief encounter, but it was an impactful one for me. And I had this vision of starting a practice in Los Angeles, and I immediately felt an affinity there. So it's really nice that we get to work together now. And for those that don't know, I'm a palliative care physician. I've been based in Montreal. I work at the Jewish General Hospital, and I've been at the intersection of introducing psychedelic-assisted therapies into the palliative care patient population here. And this week is an exciting week because it's the McGill International Palliative Care Congress. I was originally going to take our call from there, but it was a bit busy, so I'm taking it from the office. But a lot of exciting things going on, including new research in the field. I would like to highlight the newest study done at Harvard in Boston, where they gave a group of hospice patients psilocybin. And so 10 patients with median life expectancy of 2.5 to 3 months
mm,
were given psilocybin. And so those results will be announced later this afternoon. So I'm really excited about that. I think it's useful to discuss a little bit just about palliative care and about the suffering that many patients with these sorts of serious illness and terminal diagnoses face.
mm,
And so, um, the definition of palliative care that I refer to usually is the World Health Organization definition, which is, this multimodal approach to care that focuses on quality of life for patients and families facing serious illness diagnoses. And so, maybe John, you can talk a little bit about, your view on palliative care, perhaps even what brought you to palliative care,
mm.
and some of the suffering that you see that we're not really equipped to deal with well in our standard medical model.
Sure, sure. I think that's such an important piece here, and such an important piece of, I think, how I carry myself through my work and also my personhood. I think like a lot of folks, there's a personal piece here. My father struggled with several chronic illnesses and passed away about 5 years ago. But I think in retrospect, there's a recognition that as his health, as his physical health started to decline, that there was increased concerns and really challenges that impacted kind of his psychology, his well-being, and also our family dynamic, and how we were moving through our time together. And yeah, I think in retrospect, like I mentioned, there were probably opportunities for us to center maybe his quality of life in ways that maybe we didn't have a chance to, being really focused on all of the different appointments and so forth. And um, as I was trying to kind of navigate some of my own career exploration, I happened to meet an oncologist who was also a palliative care physician and split time working across both spaces, and spent some time working with him, shadowing with him, and maybe most importantly, learning from the interdisciplinary team that he was embedded on during his palliative care work. And for those that are maybe less familiar, I think palliative care is uniquely positioned to be a team sport and draws on the expertise of folks in nursing and social work and pharmacy and spiritual care, as well as medicine, to bring a more integrated and holistic model towards caring for patients as they're moving through illnesses. Um, I was just completely blown away by how they worked together as a team, how they supported each other, the patient and the family, and really made a lot of space for not just treating the symptoms of the illness, but also trying to understand the patient's experience, and their quality of life, and really understanding the suffering, the opportunities for presence, for undoing the aloneness that these illnesses can sometimes cause. And I was really drawn to their communication skills. They stepped in to spaces that I think oftentimes we collectively in medicine sometimes struggle with: how we navigate delivering bad news, um, how we partner with our patients when we feel like we may not have more disease-directed treatments that will kind of cure an illness or something like that. And so I think part of your original question was trying to kind of understand and define palliative care. And I certainly wanted to share a little bit about my personal journey, kind of moving through psychiatry and then palliative care, but wanted to highlight that a lot of folks that I meet in clinic and in the hospital hear the word palliative care and bristle and fear that this is a um a sign that one might be dying, or that this is a sign that it's the end, or have even been referred to as a death doctor, and sometimes not in the best light. And while those things are all important to hold and to respond to, I think it's important to recognize the legacy of hospice care that I know maybe you can expand on with your Montreal roots, but that palliative care is a specialty that has grown from providing expert care for folks with serious illnesses, and has in some ways maybe worked backwards from the end of life. And I really push back now and say the definition of palliative care, it really can start at the day of diagnosis. It's important to center patients' quality of life, their symptom management, how they're coping, how their family is functioning from day one. And I think that gives us a huge opportunity to be partners through the good, through the bad, just there for all of it. And that's a real privilege. Maybe I can ask you to talk about kind of the legacy that you have kind of grown up in professionally and found yourself in Montreal.
Thanks, John. Yeah, first of all, thanks for sharing that personal note. It means a lot. And yeah, I think you explained it really well. Montreal and McGill particularly is where the term palliative care was coined. So I'm proud to be affiliated with this legacy here. And just like you said, palliative care was essentially adopted from hospice care. And so if we look at hospice care as end of life care, which is what most people think palliative care is, Bal Mount, who was a urologic surgeon at McGill, was really inspired by Cicely Saunders and others. A lot of the hospice work was done in Europe, especially in the UK. And so he was inspired by that work and, essentially came to the conclusion that applying those principles of care earlier in the course of illness can be really beneficial for patients.
Mm,
And so, really, the goal of palliative care is early palliative care. Like you said, it's really ideally at the time of diagnosis. The research that exists backs the fact that patients who receive early palliative care end up doing better in their cancer treatment. And my personal clinical experience definitely validates that.
mm,
Patients dealing with cancer treatments, with all the appointments and procedures and side effects, and all the fear from every single diagnostic test, benefit from having a professional that is just there, focused on their well-being,
mm,
focused on the quality of their experience. Their success isn't just based on the test results, but how are they moving through this journey? And I think that's the beauty of palliative care. And what you said about the stigma that exists in healthcare and even in society.
mm,
I think with regards to death in modern times, at the conference opening 2 nights ago, one of the authors I was speaking, she was like, the only place we see death is in the refrigerator or something like that. But we've been moved away from death, whether it's the death of, let's say, the animals that we consume, or the death of our loved ones that's been more and more institutionalized. Both birth and death have been extremely institutionalized. And so there is that taboo and stigma. And I can say from my own experience, having gone to medical school at McGill and then residency, we did do palliative care training in both.
mm,
And my experience doing that was a little bit avoidant as well.
mm,
What what really stood out to me was the quality of care and the quality of the healthcare professionals and how they treated themselves, the patients, and us, the trainees, with a lot of dignity and respect, something that was often lacking in many other specialties. So I had this positive, felt sense from my experience, but I was a bit avoidant of dealing with death and dying. I still found it challenging, even though I knew that it's a very meaningful practice. I still, wasn't able to fully dive into it until I started working, and I spent a few years traveling to various rural communities and villages, and doing some palliative care. So, I would go to these institutions where you're the
mm,
emergency doctor, you're the hospitalist, you're everything, and you just have to do it. And then once I started providing that palliative care myself, I realized the impact one makes when providing this care. And I think that is, what most people don't realize until they're in that situation themselves, is, the impact you make on the patients and their families when you help them navigate this difficult transition is just, it's beyond words, and it's definitely one of the most gratifying feelings I've experienced as a healthcare provider. And so, my journey pivoting towards a specialty in palliative care was actually coinciding with patients receiving access to psilocybin, through the palliative care lens. And psychedelic-assisted therapy is something that I was drawn to from my undergraduate studies at UC Berkeley. And so it was the optimal opportunity for me to delve into this specialty and combine these two interests. And to bring in that personal note, many may know that my sort of original trauma was the loss of my mother. And so I lost my mother at the age of 2.5.
Mm,
It's something that really impacted my life, and I had no memory of. And
mm,
so it was like a lot of working in the subconscious to resolve and continue to work on that trauma. But what I realized is that I had become the physician who would have cared for my mother, who at the young age of 30 got a cancer diagnosis and actually passed away within weeks. So she was diagnosed with advanced cancer. And so for me doing this work, it became sort of full circle of going back to my trauma and becoming the professional that would have helped my mother. And so I can offer that help to others that are in a similar position.
what a powerful gift you've been able to make of that experience and to bring forward in a way that can be of service to others. Um, I'm grateful for you sharing that and wondering if maybe you want to touch a little bit about how at this tipping point of coming into palliative care and the access to psilocybin um, for patients who might be facing that kind of psychological distress, kind of what those experiences may have been like, or even introducing a patient case.
Thanks. Yeah, I mean, one of the interesting things about, psychedelic therapy is that no two experiences are the same. And so the same patient will have a different experience with every, session. And of course, the variety exists within various patients. And so, what we've seen has been an array of experiences. One of the concepts that we hold dear in palliative care, in psychedelic therapy, is that we believe that what comes up in the psyche during these experiences is what's sort of needed to come up. So the experience essentially, there's a wisdom that guides this experience. And
Mm,
so there are a lot of cases that can be talked about. I think just to sort of take it a step back, it's good to talk about the suffering
mm,
uh, that exists and the difficulty we have using conventional methods to address that. And so that's one of the things that stood out to me doing this work is, people are facing not only physical symptoms, but psychological symptoms. And, the word spiritual is actually in the definition of palliative care. And this is a word that, I found interesting. I've personally been attracted to, what's called spirituality. Um, but at the same time, I respect the scientific method. And so, I feel like there's this antagonism between some of the sort of dominant thoughts in science and accepting spirituality. Where I stand is that I think spirituality actually has a science behind it, and that we just haven't gotten there. And so I
mm,
think it's a matter of time, perhaps through physics and these sorts of sciences, we'll be able to understand what that is. But I think one way to look at it is simply things that don't fall into just your classic physiologic and psychological domains.
mm,
And so the sort of distress seen in this patient population is not just physical and psychological, but also spiritual. And with psychedelics, what I've seen is that you can address all of those domains.
mm,
In palliative care, let's say from the physiologic domain, let's say like pain and gastrointestinal type symptoms, we've certainly made a lot of progress. We have a lot of tools now to be able to help patients in those domains. Of course, not perfectly. One of the things we see often is that, to soothe someone's pain adequately, they may need very high doses of medications, which would sort of lower their level of consciousness. And so a lot of patients are struggling because they don't want to be sedated. They want to be alert and awake for their experience. And so a lot of them do end up enduring pain.
Mm.
But the psycho-spiritual domain, I found that the tools that we have are just not adequate enough. And so I think that's where psychedelics can play a very important role in terms of addressing that psychological suffering, and perhaps in terms of bringing a new sense of meaning for that existential type distress, the spiritual type distress, with a lifetime of memories and values and emotions potentially coming to an end.
Mm.
So I'm wondering if you're seeing the same thing on your end, and what your view is on the common tools that we have, and if you see this need in your current practice to have something different.
I think so much of what you just said completely resonates, is just hitting me right, right in the core. And with my work, a huge component of my work as a psychiatrist is with patients that are navigating their own cancer diagnoses, either very early in the process or sometimes in moments of um, where they've just learned that a disease has come back, that they have recurred now with, perhaps metastatic, widely spread disease. And other times I'm meeting folks that may be closer to the end of their life. And so really across a spectrum of the illness experience. And I can say that at all of those stages, I am meeting patients who are not maybe responding to kind of the standard antidepressant, anxiolytic medication that we would reach for in a general mental health clinic, that we would reach for in common psychiatry practice, or that the kind of evidence-based algorithms for care, evidence-based um, spaces would suggest that we reach for. And so, yeah, absolutely, it's very much echoing what you just said.
Yeah, it's I feel like in mental health and palliative care, perhaps these are two domains where our conventional treatments are really, not addressing the degree of suffering that society is facing. Some of it, of course, has other contributing factors. Let's say, when we look at this biopsychosocial and perhaps even spiritual approach to care, there are a lot of social challenges in our society. And of course, people come in, let's say, with loneliness, with isolation. And this could happen both in the context of just mental health alone, or let's say mental health as a consequence of a serious illness. And so it's not, you can't fix these problems with just a pill, and especially, antidepressants, of course, you're the expert, but they do have a very important role. They do result in things like neuroplasticity, which is, what we aim to get out of psychedelic therapy. But what I find unique about psychedelic therapy is, it's about the experience. It's
Mm.
about creating healing experiences. And, sometimes in order to really be able to break through the barriers, the defenses that, most of us end up building in a protective way, probably mostly earlier in life.
Sure.
It's hard to bring those guards down in this sort of chronic use of antidepressants without significant therapy. And in the case of serious illness, where you either don't have the time or the bandwidth or the resources,
Or the
um,
access. Yeah. Yeah.
that, yeah.
Yeah.
So that's why I really, what I've found in my experiences is that not everyone responds the same to these therapies. I think it's true for any sort of therapy, and even the same medication will have a different impact on any given individual.
Sure.
But yeah, but the experiences that are created are meaningful, and I would say the majority of them are extremely positively impactful. And yeah, I feel really privileged to be able to do this work that I do.
I want to add kind of elaborate on a piece that you brought up, earlier. I think that is really key in this intersection of mental health and serious illness and considering psychedelic assisted therapy is when we're thinking about confronting and coping with a serious illness. One of the themes that comes up so regularly for me is the tools that patients have used over the years, perhaps for managing stress or coping with hard times, sometimes become out of reach or harder to engage in. And this is just like what you said, social relationships that are affirming, communities that one might be a member of that require, physical participation or even virtual participation, um, participating in organized religion, participating in hobbies, um, and physical activity, like I mentioned before. And so when we think of just hallmark symptoms of getting, maybe weaker or fatigue or pain or shortness of breath, or just general distress, these are things that distance those mechanisms for coping from patients and strain relationships too. And so I'm hearing in what you're describing as maybe even a way to try and grow into a new kind of coping or maybe re-engage with kind of these classic coping styles in a new way. And I'll just highlight kind of one of the things that I have been really excited about as I'm, reading more literature around this space, and of course trying to keep up with um, a number of larger studies looking in particular at psilocybin around depression and so forth, is how compelling some of the qualitative pieces that researchers are describing are, and in particular, some of the secondary endpoints. They may not be the primary focus of some of the studies. We're looking at these validated scales that are trying to capture depression signal very much in the way that we would for major depression outside of a serious illness setting. But when we are looking at kind of the psychological distress that serious illness may also generate, I do think there's a lot of overlap with major depressive disorder, but I also wonder there's more there. There can be more there. There can be stronger existential and spiritual pieces, questions of meaning, questions of understanding, questions of why me, and these things really push us, I think, into understanding what are the right kinds of interventions. And I think the secondary endpoints that I'm talking about are things like measures of feeling connected to other people, feeling connected even to yourself, feeling more comfortable in your own body, um, identifying more ability to make meaning during a period of illness, being gentler with yourself, and and really even just in general talking about being better able to cope with illness. These things sound really compelling, really good fit for managing some of the serious illness distress that I'm seeing that I think goes beyond what we see with kind of the general antidepressants that also can be very helpful in more classical depression. So I'm also seeing and hearing and reflecting back to you some kind of additional edge of benefit or additional kind of fit of benefit, or really just something really exciting for us to better understand,
Yeah,
which might
thanks.
be intuitive for folks that are already working in this space. But I want to highlight that we're also seeing that captured in the research that's being done as well, which I think is helpful for patients and clinicians alike.
Thanks. Yeah, I think that's really important. These points are really important. I know that we have a lot of professionals on the call who are familiar, but for those that might not be, the way we have to do research in these domains There's no like laboratory test or imaging that you can do to assess, one's psyche. And so we have to sort of resort to these assessments that are either self-reported or clinician administered. And so, that's how we gain insights into the details of a patient's experience. And I think these domains that you touched upon are extremely important. And it's really nice to see more and more of these scales developed and validated through research that touch upon these points that perhaps weren't really measured as well in the past.
Mm,
And I think it is really important to emphasize what you said in terms of the suffering that accompanies that serious illness diagnosis and experience differs in certain ways with your, let's say, standard depression. And what we're struggling with right now in Canada is getting access for some patients that don't clearly fall into this category of, let's say, end of life distress. And
sure,
so,
sure.
yeah,
Yeah.
so Health Canada essentially started giving exemptions to certain individuals, that had this palliative diagnosis. And that system is evolving. Where it stands currently is that two groups of patients get access to psilocybin. One group is, someone who clearly has a terminal illness.
Mm,
Now, it doesn't have to be end of life, but it has to be an incurable cancer that has some sort of foreseeable prognosis.
okay.
So, it doesn't necessarily have to be under 1 year, but there has to be some sort of clear ending. And so individuals that fit that criteria get access a lot easier. And so
Mm,
what they have in their sort of structure is if there is a medical emergency, they call it. And I have a little bit of problem with that because someone in a true medical emergency is not someone we want to treat with psilocybin. It's someone we want to send to the emergency room.
mm,
But that's what they call it. They call it medical emergency, and it really means that there is some form of terminal illness in the picture. And so what's happening now is, for example, a patient of mine who his cancer is in remission, and technically, he doesn't have a terminal illness because the tests that he does every 3 months are sort of remaining negative, but his experience as a patient is completely different than someone that has major depressive disorder. And that's the
mm,
other category of patients that get access are ones with treatment resistant major depressive disorder that have tried, every single option out there, and they can come and apply for psilocybin as a last resort. And so this individual, for example, is someone that has had cancer, and a lot of times what happens is someone that's had some depression, anxiety in their life end up getting a cancer diagnosis, and then that depression, anxiety intensifies and it starts transforming. And then what I've seen is that, patients get treated, the cancer responds initially, and then there's a recurrence. And so the
mm,
cancer recurs. At the time of recurrence, the whole thing gets a lot more complicated, and
yeah.
the degree of suffering really increases. And then, what they're dealing with then is really not your classic depression, anxiety anymore. These patients, as I mentioned, often have anxiety related to the tests they're doing. And
Of
then a
course.
lot of them, yeah, they have permanent side effects because of the treatments, cancer treatments that have been done. And so to categorize these patients as your typical treatment-resistant depression just doesn't make sense. And so that's one of the, arguments we're having currently with Health Canada. And so that just validates your point that, the kind of suffering is different, and the kind of tools, required to address that suffering are different and non-existent in our standard healthcare system.
Yeah, absolutely. I guess I'm really just I'm sitting with this really important piece of kind of bringing more indications or kind of bringing more um reasons or diagnoses forward that allow us maybe more bandwidth to be thinking about these things. I know in palliative care we are talking a lot about grief, coping with loss. We'll use language like demoralization, and ultimately these are all this is all just language that's trying to identify more nuance in these spaces of what a lived experience with a serious illness is like. And that can be with or without pre-existing kind of mental health diagnoses. I mean, I think the example you gave about pre-existing kind of depression, anxiety that gets flared and amplified and transformed is so common and is something that I feel like oftentimes we're maybe not even giving enough credit to in the preparation for the disease treatment process, um, which I think kind of leaves folks at risk for there being traumatic elements to their care. Um, and I'm taking us a little bit afield here, but I get really excited thinking about, well, let's also be studying like when is the right time to be thinking about an intervention like a psychedelic-assisted therapy or a ketamine-assisted psychotherapy in the illness sequence? Are we waiting for folks that are experiencing really accelerated, heightened distress closer to the end of life? Or are there reasons for us to be thinking about these types of interventions at the time of diagnosis, pulling back and having more kind of grounding to grapple with this life transforming conversation that has happened? Or at that inflection point, that time of recurrence that you shared, is that another time to maybe be thinking about these interventions? And I'm really excited about our research and our shared collaborations and the work in this space, kind of building not just kind of the foundation, but getting into some of the nitty-gritty here about, are there these other spaces that therapies like this could be helpful? Because I think we need to take a really big global look at what caring for folks moving through big illnesses looks like. Um, and not even them, also their caregivers. I mean, we haven't talked about that at all. I don't know if that's something that you're excited about or thinking about, but expanding this to more than just the identified patient.
Yeah, thank you. Thanks for bringing that up. I mean, first of all, I think it's extremely important to address these things earlier on.
Mm,
I think um, it's not just the healthcare system, but many patients as well aren't ready to deal with some of these sort of issues at the time of diagnosis. But I think it should be offered. And I think, one way to look at it is if you believe in the notion that your body has some sort of wisdom, and if you look at disease as a message sort of coming from the body, um, you can look at any life challenge that way, really. But when you're faced with a difficult situation, my personal approach is to take a step back and
mm,
to really, look at things from a different lens and use the opportunity of adversity, as an opportunity for growth. And so
mm,
that's my personal approach. It's not always successful, but I've had a very eventful life. And really, at these difficult intersections, I've tried to at least take a step back and see what are the things I can learn from my current situation. How can I improve? And so I think offering this approach to healing early in the course of illness, and really, from my perspective, even maybe as a preventative measure, if we
mm,
look at the population and we look at how most of our diseases are preventable, most of the diseases that we're treating in the healthcare system can be prevented. in an ideal society, ideal lifestyle. So there's a lot of work to be done. But if we talk about sort of the palliative patient population, I certainly think there's a role to offer, maybe not always a drug-assisted therapy, but some form of therapy. And that's important to note is that, yeah, we're not, emphasizing the importance of just the molecule used in the treatment, but it's the overall framework, the overall approach that matters, and the molecule acts as a substance in that process. And so it's almost, this assisted therapy is a catalyst to the sort of healing that we hope to attain. And one of the ways to define healing is if we look at sort of the notion of curing. you know the ideal is if you have a serious illness, we would like to cure it. That's
Sure.
I would say that's
Sure.
the ideal goal in medicine, is to save lives, to prolong lives, and to cure. But we can't do that in many or even most circumstances. And so this notion of healing is something that can happen regardless of the course of illness. So you can heal at death's door. And a lot of that healing is a relational process. So it has to do with your relationship to yourself, to your healthcare provider, to your loved ones. And I think that's why bringing in the loved ones into this therapeutic frame and container is extremely important. Something that's not done enough, in a system where we generally lack resources, and let's just say time being one resource. People are just so busy,
Yeah.
as caregivers, especially, and we have more and more caregivers. The statistics are staggering. Essentially, I think like 50% of the US population is either going to be or is already some sort of caregiver.
Mm.
Yeah. So it's a huge burden being a caregiver. And, it really often comes with a lot of self-sacrifice. And so, if we just look at the lens of let's provide care to these caregivers, what we're doing is we're actually indirectly even helping our patients, because
Mm.
our patients are getting care from these people. So if they're in a better state, then, everyone benefits. And really, I mean, I think that applies to society as a whole. The more we take care of each other, I think that just feeds into this loop of everyone benefiting.
Mm. Mm.
So, yeah, I think it is important to note that, we've been talking at psilocybin, and, the research with psilocybin for this patient population, from my knowledge, actually started with Charlie Grobe at UCLA. And, that was, I think, around 2010. Before that, there was a hiatus in psychedelic research. The research started, a lot of it, with LSD in the 50s and 60s, applied to patients with advanced cancer. Very interesting results. And then there was this hiatus in research until this new wave that started at UCLA and showed positive results. And then that led to the two randomized controlled trials done at NYU and Johns Hopkins, again, using psilocybin for patients with advanced cancer, with, very promising results. And now there's a multi-site study between all these institutions, and I think UCSF as well, that is about to launch. I think there was a bit of a holdback because of the California situation.
Sure.
um, and so psilocybin, from my experience, really has been amazing for this patient population. But there's a question of access, especially in the United States.
Mm.
Outside of these clinical trials, you don't have proper access in the medical system. Of course, in Oregon, you have psilocybin services now that can be used in this frame, but they're not meant to be used in the medical sort of approach. And Colorado is now rolling out their programs, and I think they are allowing for more of a medical integrated type approach. But in California now, with our practice launching, the tool that we will be using is ketamine.
Hmm.
And I think it's worth talking about ketamine. Ketamine's a bit of a sort of hot topic now because of recent tragic death of Matthew Perry. And so I think it's just worth mentioning that ketamine is an amazing medicine that's been around for decades, approved primarily as an anesthetic agent, but found to have these antidepressant properties dating back decades and more researched recently. And we have S-ketamine, known as Spravato, which is, let's say, one half of the ketamine sort of compound, already approved for treatment-resistant depression and suicidality. And so I'm really excited to work with ketamine because not only it has these properties for pain relief, for this ability to dissociate from the body to some degree. And a lot of people are suffering because of being stuck in the body with chronic pain or disease-related pain. So it gives that opportunity, but it also is considered by many a psychedelic.
Hmm.
And so, the word psychedelic, sort of hints at mind manifesting. And so the idea is content from the subconscious can emerge, parts of the psyche that we don't normally have access to. And so ketamine used in that way is an extremely powerful tool that, we can use in this psychedelic assisted therapy framework. And
Mhm.
so I'm really excited for that. And I'm wondering what your thoughts are on that.
Yeah, I'm glad that we kind of made that pivot. And I guess I wanted to highlight one of the really important takeaways from, listening to the first webinar that you did with Matt Baldwin was just thinking about how different dose ranges of ketamine confer different benefits or different properties. And so I'm thinking a lot about how you described its introduction, right, as an anesthetic, something that was used, in combat and for procedural sedation and is used historically for anesthesia for children and adolescents very safely. Um, and how we're also starting to become more comfortable with taking advantage of its antidepressant properties. I will also say in parallel, there has been a lot of development around using it for pain relief, like you mentioned briefly, but I wanted to elaborate a little bit. This is a medicine that is widely used, regularly used in the chronic pain and acute pain space, and is in particular used in the palliative care setting because it's well tolerated and safe for kind of these advanced, challenging, sometimes not as opioid sensitive cancer pains and other types of pain profiles. This is a molecule, this is a medicine that we use, that we use. It is not something that is being kind of taken off the shelf after being gone for a long time. And I think that gives us, I think, a lot of flexibility. It gives us a lot of, in my opinion, as someone who's coming into this space, a lot of, I think, reassurance that it has been well studied. And that's something that I certainly want to make sure that, folks, especially patients or family members, are holding very, very sensitively. I will
Yeah.
also say that this is something that's been studied in the serious illness population, in the hospice population. And oral ketamine has been given to hospice patients and shown good effects on anxiety and depression. And data from Scott Irwin's group, now at Cedars-Sinai, previously at UCSD and San Diego Hospice. These are a medicine that we're using in really thoughtful ways. And so I'm really excited to see how that develops with the work that you're doing.
Yeah. Yeah. Thank you. It is a powerful, analgesic agent, addressing pain that is difficult to treat, and it works quite quickly. I actually, before, getting into psychedelic assisted therapy as a healthcare professional, I did a lot of emergency room work. And so I
Mm,
did use a lot of ketamine as procedural sedation. And at that time, probably like many clinicians, I wasn't aware of how profoundly powerful it is. And so, especially at some of the higher doses that we use in very painful procedures, patients were having really significant experiences. And so,
Yeah. Yeah.
I think more and more we appreciate that side of it. And what was really considered a side effect is now being utilized as a tool for transformation. And so, um, it's been really exciting doing the work with psilocybin in this patient population and with MDMA for the PTSD population. But I think ketamine as this very versatile tool that is approved, has been used for decades, is extremely safe for many people, can be used in a very skillful way to address various challenges that our patients face. It's interesting because the most common response from people when you talk about ketamine is that the horse tranquilizer, which is interesting. And the reality is we're all mammals, and so a lot of the medications work across the sort of mammalian spectrum. So yeah, it can be used as a horse tranquilizer, but before that, it was used in humans, and
Yeah.
yeah, and
Yeah.
in combat, like you said, in the Vietnam War especially.
Yeah.
So yeah, I'm really excited about rolling out our ketamine-assisted therapy program. And the way we approach it for most patients is really pairing the ketamine with psychotherapy. And I'm really happy that we've onboarded some very skilled psychotherapists. And we'll be able to hopefully foster transformational change for our patients and caregivers as we launch this practice.
It's a really, really exciting big step.
Thank you. Thanks a lot. I know that we have about 5 minutes left. Um, Kabir, do we have any particular questions that have come up?
There aren't any questions that have come up in this conversation here, but just out of curiosity, I know it's come up outside of this conversation. Will we only be supporting patients in California, or is there an opportunity to support patients across the border in Canada as well? I know that has come up, and there's another question here as well, but if we can start with that one, that'd be great.
Thanks. Yes, no, the intention is to offer services in Canada as well. The situation in Canada has been that a lot of people have been reaching out, seeking help, and I just haven't had the bandwidth to be able to provide that. But I recently was involved in devising a ketamine protocol for the palliative care service at our hospital. So, in collaboration with our psychiatrist and pharmacy teams, we essentially adapted their depression protocol using ketamine for palliative patients. So I'm really excited to officially start offering that at the hospital. And I think once we have our operations in LA rolling, I'm going to have these services available in Montreal and hopefully maybe expanding to other provinces eventually as well, and even other US sort of cities and states.
Thank you. Thank you for that. There's a question for you that I just shared in the chat over here, John. Um, I just wanted to say that this has been, it's such an informative conversation. Being a part of this space over here and having the pleasure of, working with the team, Dr. Houman, yeah, this has been, I'm really looking forward to revisiting this. And for those of you who are joining us, this is going to be up on YouTube. This is going to be available. If you'd like to go ahead and share it with anyone or perhaps revisit it, I'll be sharing a follow-up email after the session.
Do I have a moment to comment on the question?
Yes, please. Of course you do.
And
Yes, you
would it
do.
be helpful for me to read it out loud? It's for the audience.
Sure. Yes, please. Thank you. Thank you.
So the question is first commenting on kind of just there's a lack of extensive data on ketamine in the end of life population, and just wondering, would it be reasonable to translate the data evaluating psilocybin's effects on depression, anxiety in cancer patients to ketamine? Um, and I want to comment on both of the, there's kind of two big parts there. Um, One is there is some data on ketamine in the end of life population. Looking most of what I've seen is actually with oral ketamine to try and treat end of life anxiety and depression, in addition to it being studied for pain. But I think in looking at the depression anxiety space, I do think there is good data, in particular from Scott Irwin's group, that's highlighting that, but small studies. And part of that may be that there isn't a large kind of infrastructure push to study in medicine that kind of isn't as aligned with maybe big pharma wanting to study something that is already widely available. I think the second big question here is, would it be appropriate to translate psilocybin's effects? And I would say, I don't know if we need to. I'm not sure we need to. And I want to give plenty of space for ketamine to be more and further studied, for the CAP model, the ketamine-assisted psychotherapy model, also to be studied more. There are a lot of people that are doing that actively right now. I can't comment on why we're just getting a little bit more a momentum now. I wish it was 5, 10, 20 years ago. Um, but I think some of the data around ketamine in anxiety and depression outside of the end of life population that has happened and has created a lot of interest recently is maybe driving some of the resurgence in its interest in these other spaces. So that, coupled with really just the dire need for more tools, more safe tools to thoughtfully address suffering in a vulnerable population like those that are facing serious illness, I think that's driving some of the new momentum now. But I do think there's good data there already. And I would say we don't need to extrapolate from psilocybin and can allow them to both kind of blossom and grow in their own spaces as well. I'll pitch it to Houman as well if you want to comment on that.
Thanks. No, I think you said it perfectly. Thank you for that.
Thank you, Dr. Horton. Thank you. If there's any last closing remarks, I feel like we're up on the hour here. It would be just to create the space for that. And there are not any other questions, in the chat here. But if there's anything else that you'd like to share, any closing notes?
Thanks, Kabir. No, I think that was a really lovely session. It's always a pleasure to spend time and to talk with John and learn and bounce ideas. And I know that we're going to have these webinars regularly. So, I look forward to also giving a bit of a recap on some of the findings that we're going to see in this conference and with Dr. Yvonne Poisson's group in Boston. And hopefully we'll be able to also conduct our own research and to add to the need of more data for using ketamine in this patient population.
Thank you, Dr.
I just wanted to extend a warm thank you for having me. And I'm excited for what comes next.
Thanks, John.
Thank you,
Thanks.
Dr. Horton.
Thanks, everyone.
Thank you, everyone, for joining today. Have a wonderful, wonderful rest of your day.